They told me it works. I've seen it work. Let's do it. If we don't do it, your quad, your leg, your limb will be small. If we do it, we'll minimize that atrophy. So combining BFR and the Neubie in the same session, I'm 30 minutes into a really effective treatment, and I know they're getting better while they're doing those things. And then I can educate them. We can talk. I can get to know them. It's essentially speed dating. We've got to get to know each other quickly, but we can't waste time and not work. Mm-hmm. So those two things in tandem or in same session, I think are very valuable, the BFR and the Neubie. And we've talked through.
I'm Garrett Salpeter, and I believe that the most powerful and transformative way to help people recover from pain and injury, heal from trauma, and reach their highest levels of fitness and performance is to focus on the nervous system. In this podcast, we'll share knowledge from the frontiers of neuroscience and inspirational stories of how applying that knowledge has empowered people from all walks of life to heal, adapt, and grow. Welcome to this episode of the NeuFit Undercurrent podcast. We are going to do a deep dive into sports medicine with my friend, colleague, and partner, Cullen Nigrini, a physical therapist, athletic trainer, also an SCS and OCS. We'll talk about what those designations mean. Cullen has been treating athletes for many years at the University of Texas. He was doing that full time, actually left Austin to go work in professional basketball with an NBA team for a couple of years, came back in Austin, was working in private practice, still treating athletes at UT. We had a friendship for many years, and finally were able to join forces at the time of this recording, just over a year and a half ago, able to work together here to beef up physical therapy services here at the NeuFit clinic in Austin, Texas. So Cullen is officially our head of sports medicine and is running the clinic here in Austin. And it's really a tremendous honor to have you not only on the team, but to be recording with you here today.
Absolutely. Thank you, Garrett.
Yes. So today we'll get to talk about sports medicine, also look a little bit behind the scenes in the world of big time Division I sports and professional sports, and then talk about how you're able to take that experience and bring it locally to provide that that high quality level of care here in the community. So we've got a lot to cover. To start, just so people can understand a little bit about your background, if people don't know what that SCS and OCS designations are, can you just educate us on that? Let us know what those mean.
Sure, I'd love to. And this one talking point, the American Board of Physical Therapy Specialties. I always want to clear my acronyms, so that ABPTS. And within physical therapy, they've got a governing body that has designated specialties based on disciplines. Sports certification is one of them. The orthopedic certification is the second. Orthopedic is the largest of all of the boards, meaning we have the most members that are OCS. So it's the most common, still a very rigorous exam that you have to take. This is postgraduate. So you've gotten out of school, you've practiced for an allotted amount of time in the right levels, and they allow you to sit for the exam. So I have the OCS, the orthopedic certification, as well as the sports certification. And the goal of the sports certification is to mend that divide between athletic training, physical therapy, sports physical therapy, and all points in between, to just be part of that sports medicine team because of the nuances and differences between outpatient orthopedic therapy, athletics, and then where I work, which is in the fringe.
And the metaphor that I think of, or kind of the comparative framework that I think of, is that these are sort of the equivalent of the fellowships that a surgeon might do to learn specific hip or knee techniques or stuff like that. These are essentially the physical therapy equivalent of fellowships?
They do. And we have the ability to have a fellowship, which oftentimes prepares you for this exam. It's one of the goals of some of the fellowship programs. We have residencies, but this specifically is just the exam to say, not only did I potentially do a fellowship, but I also am board certified in this specialty, and it lasts for 10 years. So actually, just not to date ourselves, but I've redone both certifications in the last 18 months. So I've got another 10 years, and we'll cross that bridge in a decade as far as what's next for us.
Nice. So I'll give a shout out to John DeBella, my good friend from growing up, who was your first cousin who connected us, because you were the first person I met when I came to Austin for my engineering graduate school back in 2008. Speaking of dating ourselves.
That's right.
And so shout out there. So back in that day, you had just completed your physical therapy schooling, but you had been an athletic trainer first.
Correct.
So tell us a little bit about your early career in athletic training, what inspired you to go on and become a PT in addition, and a little bit about that transition and experience.
Sure. And all of our paths. So that path I chose was what led me ultimately here, but starting knowing I didn't know what I wanted to be when I grew up, and sort of that Peter Pan confusion, which is good and bad. Almost through my undergraduate experience at the University of Colorado, I wasn't sure what I was going to do with that degree. I had a friend that was a physical therapy provider. He had just gone to that route. He loved it, said it's a great profession. He encouraged me to go look into athletic training because of my interest in sports. And so at that time, I was able to do an internship route to licensure. That route no longer exists. In fact, it's now transitioning to a master's degree. Mm-hmm. So to now have what I have, you'd be required to go to graduate school for both physical therapy and athletic training. So it's a pretty daunting task. So I feel fortunate that my route enabled me to get there a little more swiftly than others. So we did that. The next steps would be to be a graduate assistant, work in athletics at the D-1 setting, and that will set the stage if you want to stay in athletics. If you've done that, you've shown, I belong in this field. I can now become a collegiate staff therapist, a high school staff therapist, even working in the pros. So I came to the University of Texas to do that here, and that's where Austin has become home for me with that experience at the University of Texas. Then PT school, roll that into when we met, when I just finished my PT school experience, but that gave me the sports experience on the front end versus some that are trying to gain it after they become a physical therapist. Mm-hmm. So just really fortunate to have those sports contacts already made, and the physical therapy was another step to further my journey.
And you had worked as an athletic trainer at UT and then essentially left to go to PT school and then came back and did more work there.
Correct.
Okay.
Correct. Finished my graduate assistantship, had a summer internship with the Cowboys, thought I was going to find my way, apply to PT school and potentially get in. They created actually a job for me before I got admitted to PT school. So I was a full-time staff member for a year with football, and that's when I learned I was admitted to PT school. Mm-hmm. So my mentor there, Alan Harden, really convinced me just to go ahead. We'll be here. I'll be here. Get your physical therapy degree, and if we can work again, we will. And that's happened. And just like we've talked about, if we can ever do something together, we will. So nice. Here we are.
Shout out to Alan Harden, a great leader. He's the head of the sports medicine department here at UT. And
yes.
Now an associate athletic director too, right?
Correct.
Yes. Very good. Can you tell us a little bit of just that whole experience, what it's like, both when you were there as a full-time athletic trainer and now when you're there part-time as a PT, but what's it like treating athletes, especially for people listening who are in private practice physical therapy, for example, or out working in the community? What's it like in the Division I setting? How's it similar? How's it different? Just kind of what stands out about your experience in that environment?
Great question, and the it just depends answers will start rolling from me now because it depends on your role. Mm-hmm. So my role is different than that of the full-time athletic trainer that is at every game, practice, pre-treatment, post-treatment, and what a commitment that is, but how relationships are nurtured. I always say a month in that field is like a year outside of the field. Mm-hmm. Just in contacts, human interactions, you spend more time with that team than you do your family. You get to know them really well. Mm-hmm. So in 4 years from someone that's a freshman to a senior, gosh, you really have a good idea of what they're about, and they have a good insights to you. Mm-hmm. So it becomes more of a family in that essence. Outpatient therapy, you may see someone 10 times over a 6-week period, and you have a good relationship. But it's to me, that's the greatest difference. Mm-hmm. Not to get into the weeds of what your day is like, but I think the relationship is different there, and the time just really does fly and stack up. Mm-hmm. So I think that's very standout as far as a difference.
Yeah, that makes a lot of sense. And that's consistent. Some of the athletic trainers with the pro teams that we work with, they're, I can tell they have the good relationship with guys. They're calling on behalf of guys to rent them machines for their personal stuff. And they help them with all sorts. They're just really, you can tell they have a close relationship too.
It's the hats. You wear many more hats
Yeah.
because, and we do a good job at the university level to have a multidisciplinary team, to have multiple resources, but that doesn't mean you're not that gatekeeper where you have to shepherd someone into, hey, it looks like you may need nutritional services. We luckily at UT we have everything, so it's very easy to send them down the hallway. Other universities aren't as fortunate, and hopefully they have the local contact. They might have a physical therapist on staff, so they have a local rehab place where that athlete may need a different kind of attention than they're able to give in the middle of the season. So they go off campus and go to physical therapy elsewhere. Physicians, it really is helpful to have those resources and be able to wear the hat, but quickly take it off and just tell people where to go to get that help. And that's where we want to go with what we do is to be that local contact for the general public, whether it's a high school athlete or an adult that is missing out on something. Can we not only give them the best care, but help them find what they really need?
Yeah, for sure. And we'll talk about that as well, kind of how we're bringing that into the community. So at UT, you were that athletic trainer, for a season, for a period of time. So you had that, in the grind with the guys. That was that the national championship? That was
just before.
That was the year before. That was with Mac Brown. Yeah, that's right.
Yes.
That was a good time to be with that football team.
Correct. It really make you like Austin when you get to experience the gift of athletics at that time. It was fantastic.
Yeah, that's very cool. And then what is that? So then, you went to PT school, went to New Orleans in the NBA. Now that you're back at UT, what is that, part-time physical therapist you're working with? It's a different set of the athletes. What does that role look like now? Just to kind of give people some color, from the other angle of that.
Sure. So now I'm in a more of a supportive role where the athletic trainer has that athlete every day. They also may be in the middle of the season, and that athlete could be out for the year because of an ACL reconstruction.
Yeah.
They are going to be on the road. It's going to be hard for that athlete to get what they would get if it was out of season. It's very easy for me to have clinical time for that athlete. So they know I'm in it. Every day is a real day. They're still going to see their strength coach. They're still going to see their athletic trainer. They can include me into the mix. And that for so many of the long-term rehabs, I get to have that relationship with them. And with them, I'm seeing them multiple times a week for multiple hours. So we do continue to get to know them in that way. And then also anything that I can assist with, if it's an acute need, something that we all sort of conference on that may need the special modality or certain technique that one of the athletic trainers doesn't know yet, or I was just privileged to learn 20 years ago. Those are my relationships. So it's really great. I've got a really good opportunity there to be clinical, but still keep my hands in athletics. And so I'm very, very grateful for that opportunity.
It's sort of like, as kind of my perspective, it's sort of like having a clinic, like PT clinic we have here, having a PT clinic there where the athletic trainers could send these longer term rehab cases, right? And
correct,
that sort of thing. Yeah, that's cool. How about when the 2 years when you left Austin to go work in New Orleans they weren't the Pelicans yet. They were the New Orleans Hornets.
Along the way, when I left Austin, they were the New Orleans Hornets. When I returned to Austin, they were the Pelicans.
That's right.
And there was a season of in between where we brought our family back, and then I did one more season, did a third year when I would travel back and forth.
Oh yeah, that's right.
That was great. It was a really unbelievable experience.
How does that compare then, to the professional sports versus Division I, versus private practice? What's that like?
And I think basketball is its own unique bird because 450 athletes are in the NBA. There are not many 6'7" people that can run and jump. In the rest of the world, not counting the high school sophomore that may go to the NBA, there may be 50 guys that aren't in the NBA that could be. It's a very specialized unit and very unique, and they can play for a long time. So you're given the keys to a very expensive vehicle, and hopefully you keep it on the road. The season is grueling. It's just the separation from high school to college to major Division I college to pro is very staggering. And so a lot of people that command the room, and so you learn whether you belong there or not in a hurry. I had a great organization, great coaches, great front office staff I still communicate with now. And it was a great opportunity, great experience. And we also made a decision to step back, come back to Austin, and that ultimately was the right decision for us. Yeah. So loved my time there and have no regrets. Had just a really remarkable experience.
Yes, it's tough to balance that pro sports life and the family life. I know you're a dedicated family man. I'm blessed to know your wife also. Funny story, just as an aside. So when Cullen and I met here, a few months after that, I got to know his wife, Sarah, and a few months after that, I started dating Brianna, who was my girlfriend and now, wife of almost 10 years of marriage now. And I told you and Sarah who I started dating, and it turns out that our wives knew each other from growing up in Corpus Christi, Texas.
That's right.
That was an amazing small world story.
And that's athletics, and the small overlapping circles. There are no strangers in this world, so it's our job just to all play together.
That's right. All the more incentive to treat people well.
That's right.
Right. So let's transition now from the world of Division I and professional sports to, you alluded to it already. How do we provide that quality of care that professional athletes are getting for people in the community here in Austin or in the communities of people who are listening? So what's your kind of mindset, strategy, perspective overall, looking at how you might be able to provide that quality of care for people here in the community?
Sure. I think number one, it's time. Mm-hmm. It's a different time. It's not a student athlete or a pro with not much else to do. It's a mother that needs to grab her kids in 45 minutes, and a high school kid that can't miss algebra. So you get these small windows. And if you have 45 minutes to an hour, once or twice a week, you have to maximize your effect. Mm-hmm. Starts with communication. So the thing I'll teach new grads the most, or some of my students the most, is what's the most important thing about the evaluation? It's the subjective history. You have to listen. Mm-hmm. So we listen first. That patient knows their body better than we ever will. They've also potentially experienced things. In this town, there's so many options and people play hard. They're very active. They may have experienced a multitude of different physical therapy clinics, different injuries. So I love them telling me about themselves. I never want to know what I'm going to do with somebody before they tell me what's wrong with them. From there, we go into techniques and what works well, and what fits into our program. And so that's where I've had the knowledge of many modalities, many techniques, been pushed into continuing education, have seen practitioners from all over the world. You have to know quickly what helps you get that patient better in that period of time. And so that's where I try to whittle down my tricks and tools to a select few. Mm-hmm. And I think that's why we've always come back to a working relationship, because with the Neubie, with the NeuFit method, it fits in, it's helpful, it's impactful, and that's great. If it helps me, makes me look better with the patient outcome, then that becomes a no-brainer help.
Mm-hmm. Okay. So that makes a lot of sense. I mean, I think that's something that we talk about a lot, from the perspective of both the answer to that question of how can we provide that good quality of, same type of quality of care to people here. It's how do we maximize the time, right? Get the most bang for the buck. And we talk about it from the other angle, we get kind of the same answer of if you're a private practice owner, how do you differentiate yourself to stand out in the community and have a successful practice? Ultimately, it's the same thing, right? Provide the most value to your patients so that they are excited about coming back. They want to come back. They want to complete their plan of care. They want to tell their friends and family about it. They want to tell their surgeon or their physician or anyone they can talk to about it. And I also really like that you said, listen first, that subjective is the most important. Listen to what they have to say. When we talk about then, so that's sort of the mindset or the higher level strategy, then going down one level to the tactics.
Sure.
Let's talk a little bit about that. So I obviously work with you on a daily basis, right? So know a lot about this. So I'll be able to ask a few questions that will also help with some of what we get often from other practitioners in NeuFit Nation. We get questions like, do you use dry needling and can you use the Neubie with it? Do you use blood flow restriction, BFR, and can you do the Neubie with it and stuff like that? So, I happen to know that you're well versed in and use some of those as well. So can you talk to us a little bit about how you use those in conjunction with the Neubie and fit some of those in to that end of getting the most bang for the buck, getting the most value out of that limited time that you have with patients?
Love it. Great. And one of the bigger challenges early on, being fortunate to have just a large volume of post-operative patients, big time surgeries, meaning very involved. Let's pick the knee. We've got meniscus repair. We've got weight bearing restrictions where that patient is toe touch weight bearing for 6 weeks. We're going to get atrophy. That sets us back potentially. We used to see people going to their 6-week appointment with 6-8 centimeters of atrophy compared to their non-affected limb. The thought of biohacking or maximizing potential, using technology to help us, that's where I've really wanted to go. And things that work and make sense, BFR is one of those things. And it acts on a different mechanism than the Neubie. So now we have 2 powerful ways to hypertrophy a muscle that can't be loaded. And having that conversation with people, there are things that I don't study much, but y'all have studied, we know work. So it's very easy for me to believe in something that here's the research. They told me it works. I've seen it work. Let's do it. If we don't do it, your quad, your leg, your limb will be small. If we do it, we'll minimize that atrophy. So combining BFR and the Neubie in a same session, I'm 30 minutes into a really effective treatment, and I know they're getting better while they're doing those things. And then I can educate them. We can talk. I can get to know them. It's essentially speed dating. We've got to get to know each other quickly, but we can't waste time and not work. So those 2 things in tandem or in same session, I think are very valuable, the BFR and the Neubie. And we've talked through kind of the dosage and the application, and it's an art, more of a science, but good results. I'll let you step in.
One of the things, just to kind of piggyback on that and add a little detail, for people listening, because we do get that question. One of the ways that I like to describe it is to talk about a Venn diagram where, if you have 2 overlapping circles, there's, the Neubie on one side, BFR on another, where they overlap in the middle because they both can provide hypertrophy with less external load, sometimes with just body weight or reduced external load. But where they differentiate is that the Neubie is more about neurological activation, whereas the BFR is more metabolic. And so the stimulus, is a little bit different, but you get that nice overlap in the middle. And so you can use them, like you said, you can use them sequentially in the same session or even together. And we've talked about doing that. So for people who are doing that, one tip, if you have a Neubie and you're listening to this, if you're going to do them together, we typically, if you're going to have BFR cuffs on and use the Neubie, that's great, because the other sort of Venn diagram overlap is, the Neubie is going to be more specific where the pads are applied, those neuromuscular pathways, and the BFR is going to be more general, more global for that entire limb, get these whole body or at least whole limb metabolic effects. And so one of the things that we would recommend doing would be limiting, introducing both individually first.
Yes.
Would be one, and then kind of easing into it when you're combining them, because you can get soreness and fatigue and stuff like that. And then also with the Neubie, just using the 500 pulses per second setting, so we're not getting as much of the breakdown and fatigue as we would if we're going to those middle frequencies there, because you're already getting a lot of fatigue and metabolic byproducts building up from the BFR. You don't necessarily want to get more of those from the Neubie. So those are just a few of the quick tips and a little bit of other description to add a little more color on that. But
yeah, I would say great disclaimer on middle frequency Neubie with BFR. You need a special patient, carefully selected, special practitioner, good relationship, knowing there will be some soreness. So that to me isn't something that I've digested, but there was good literature on, quickly after the BFR literature, BFR combined with NMES. So we've definitely, once that patient has experienced the BFR and they're tolerating it, they've experienced the Neubie, they love it, combine the 2. And what I like to do on those post-op knees, spend as much time as we can on the current, because if our goal is to re-educate quadriceps lower extremity function, I take a macro dose. I want them for as much as I can at that time, and I can have the BFR, go through the BFR routine. By that time, they've accommodated the signal. We can turn up their E-stim, go to the next steps, go to the next rounds of supersets. So really good cohabitive space for those two. And I encourage people to try it out. The soreness component, when you add the middle frequency, similar to the dry needling, that would be sometimes not for everyone, but still good results with dry needling over the years. Dry needling was moderately polarizing early on. Can we do it? Should we do it? I think it's more widely accepted, but it still has its place. Sometimes it's risks on the Venn diagram where you wouldn't want to necessarily do it, or too much risk involved. Instead of needling an area that's potentially too sensitive, the patient's had a negative outcome, are fearful of needles, using the NeuFit in place of is great. Using the NeuFit after to minimize soreness, I do quite frequently. It would be very much the rule where after needling, we potentially start with the most involved thing. We needle first, then we spend the rest of the time minimizing the negative effects of that needling with the Neubie device. And I see that working really well. That's one of my go-tos as far as needle then Neubie. And then we're trying to figure out, how do you incorporate intramuscular stimulation with the Neubie device? We're getting there. That'd be a future podcast.
I love that. So just, a little behind the scenes, you've done that on me. At least one time over here, we tried it out. So we played around with the different frequencies. So he had the needles, I think along my thoracic spine with the connected to the Neubie with alligator clips. And we're playing around with different frequencies and power levels and stuff like that. So, I loved it. I want to do more of it.
Yes.
I only went up to about 12 or 13.
Most of my experiences, they go to 1 to 3, and low frequency better than high. To me, the 500
just for
frequency
the
needle
sensation.
it's going to be very much a buzz and a very quick ramp. So starting with maybe a 5 hertz and a 1 or 2 on a major muscle, maybe a glute.
Yes.
I would try it on yourself. Same thing. That's a special patient, special clinician.
Yeah.
That's we'll get there. We'll get there.
That's right. So we are working. So one of the issues that we experienced, and so yes, I loved it. As a disclaimer, though, I often put the Neubie on different muscles at 100 as part of my warm up, and just love it. Right. So I'm not the person who's in there experiencing it for the first or second or third time. So just a quick disclaimer, but one of the issues is that when the current is so concentrated, an electrode is a couple square inches of surface area, right? The needle is a millimeter of surface area. So when the current is so concentrated there, it's more intense, right? And so if you go up, so if someone doesn't feel it at 1 and then all of a sudden you turn it to 2, they might feel it more intensely. So just for everybody listening, a little bit of context for why people might have some of these experiences. And so one of the things that is coming down the pipeline is working on some ways to be able to go up in smaller increments so that we can do that. So just a little preview of some of the things that we're working on and some of the things coming down the pipeline in the future. But it's a cool combination.
And that'll be fantastic. That I'm very excited for it. And that being said, I do it. I would just want to talk through it. Talk through it.
Yeah, and make sure it's someone who's comfortable with the sensation of the Neubie and understands it, and you have good rapport.
And we always go back to the why. If you're going to get the effects, is that necessary? Do you need to walk the line?
Yeah.
We want to make sure the patient is happy and comes back if they need to. And if you're challenging those two things, that's when we wouldn't do BFR in the Neubie. For the first time, I meet someone 2 days post-op and work them to the bone.
Yeah.
It's all selection.
That's right.
If you're ready to supercharge your practice, listen to this. Garrett and Team NeuFit have just released a new online course entitled Introduction to the NeuFit Method. In this detailed 8-hour course, you'll gain mastery of the fundamental techniques in our practice, including muscle testing and activations, nerve glides, and joint articulations. You'll also get introduced to our patented direct current stimulation device, the Neubie, an incredible machine that's empowered professionals just like you to help their patients heal, adapt, and grow faster than they ever thought possible. To learn more, go to www.neu.fit/learn. And now back to the show.
That's right. So I'm gonna ask you a question that I don't know what your answer is going to be. So I'll be interested. I don't think we've ever discussed this before. So when I've had dry needling done, just without the Neubie, when we're in an area and the needle's being pulsed or pumped,
Piston, yes.
pistoned is the word. Yeah, thank you. So when it's being pistoned in there, to me it feels like finding a hot spot with the Neubie and getting some sort of releasing type effect there. To me, it actually feels very similar. I feel that type of nerve sensation, deep achy in a productively uncomfortable sort of way. So we've talked about that concept of Venn diagram. If we're talking about a Venn diagram between between dry needling and the Neubie, do you see some overlap in terms of the mechanism of how you're helping to release and change the tone of tissue and stuff like that? Talk to me a little bit about your thoughts there.
My thought is I can't wait for the scientists to tell me.
Yeah, right.
Is it substance P? Is it? I don't know. I'd love to know, and I can't wait for you to figure it out and tell me. Where I think the overlap is for me is patient selection. Mm-hmm. The patient that would respond to very aggressive dry needle pistoning also probably dials up that Neubie and needs a higher intensity to get a desired result. And it has nothing to do with their injury, their state of mind, how pleasant they are to be around. It's just case by case. So that's where I really see it as a manipulative needling is someone that you're going to have to turn them up to 40 or 50 to get an effect on their quad. Mm-hmm. That's empirical. That's not peer reviewed. But that's my overlap there.
Okay. Good. Productive there. Add some perspective on that. One of the things that you and I have talked about a little bit, just in here and there, is some modalities that might be good in that pro sports setting, but might not necessarily translate into the private practice setting because, like you mentioned, the time limitation. Is there any more to say on that topic, or?
Sure, we could certainly go a long way there, and I do think it's based on the nature of one's practice. Mm-hmm. And if one's practice allows for the patient to be there longer, then there are more options for consumable modalities that may not reimburse with insurance, but are cash-based, that might require more hands-on operation. Why I love the things that I've chosen, Neubie for the example. It allows the mechanism of the direct current to be applied while they're also consuming neuromuscular education, therapeutic activity. Mm-hmm. So there's no question they're working. And that's a selling point for me. Hey, this is E-stim. Correct. But it's not unintended E-stim like I'll do with an athlete that has 8 hours. Mm-hmm. It's purposeful. We're using this electric stimulation to allow you to move more freely, to improve your range of motion because you told me you can't touch your toes and now you are. So purposeful. And it's certainly a place for every modality. For me, in my demographic, when I'm trying to move post-op patients through with the best care possible, the opportunity is there for modalities, but the threat is my time. And if I'm hands tied on one patient for too long with one modality, it's a struggle for me personally in the way I practice. But certainly case to case, clinic to clinic, there's a lot of variability there. What I see in a hands-on clinic or a hands-off clinic, a lot of new grads or expert clinicians based on years or ability, NeuFit has a place. And that's what's great. That's why I'll use it. A simple tool like vasocompression, boots, whichever company you like, that seems to work. Athletes, patients seem to like it. And it's a set it and forget it. It's the Ronco food dehydrator, the rotisserie.
The rotisserie.
Set it and forget. They love it. Great. They're happy. It helps them. They've already done their work. The work's over. And if that gives them value, I love it. And it doesn't require much for me. Mm-hmm. So that in contrast to the Neubie where we're getting work while you're here, while you're consuming, I think those would be on the polar ends of the modalities that I like to utilize. Mm-hmm. And the boots can be like a carrot we dangle. Hey, we worked hard today. You want to climb in the boots? And they love it. Mm-hmm. So that would be an example of how you can stretch it out a bit on something that doesn't require more bandwidth from me.
Let's I definitely want to hear, the other side of this, your take on how to offer good sports medicine care in the community. Talk about from a business perspective. But before we transition away from technology and modalities, what else is on your radar in terms of things that you see coming down the pipeline, or other technologies, approaches, things that you're interested in? Because I know you've got some interest here, and we talk about things from time to time.
And always the challenge, but the gift is, if in the university setting, if we don't know the tool or the modality or the technique, the athlete might go consume it elsewhere. So we at least need to be on the radar. I talk about the alphabet soup of the BFR and the NMES, and we know what all these things are, and we should. So we at least need to have cast a wide net on learning what's out there. And from there, just really trying to decipher what works well. New things, sports science, we felt like we were pioneers in the NBA 10 years ago, and we knew we needed data. And for 2 decades, I've heard about data and analytics and consulting, but my knowledge of those hasn't really come up. I have some idea, but people, that's what they do. And I know they're important. Buy-in is the most critical. So with sports science, I've watched it now over the last 5 really years take off to where you have a sports science department. And that's something that is very consumable, very helpful. So trying to bring that into outpatient private practice, that legitimizes sports medicine. It legitimizes what we do. This was your lower extremity strength. This was your quad strength. We did what we did. Now here it is. What we did worked. We did BFR. We did NMES with the Neubie. You exercised. It validates what we do internally, but the patient also consumes that validation. They know it worked. So I think sports science is something great. And from there, it's really the sports science space, the recovery space. Tale of two cities. Couldn't be more different, because the recovery is even harder to digest. We have a phenomenal sports scientist. He always tells me about the 10% rule. If you hit your recovery perfectly, you can boost your performance by about 10%.
Which is a big deal.
If you're an Olympic swimmer, that's huge.
Yeah.
If you're a casual athlete, probably won't notice much, and you have to hit it perfectly.
Yeah.
So what's the chance that you know exactly what your body needs from a recovery standpoint?
That's not just sleeping at night, but this is like
the whole
this is like super compensation and peaking and periodization.
Yes.
If you're talking about that,
Cryotherapy, IV drips, take your pick, and it's a great industry. And a lot of things, it's if it feels good and it makes sense to you, consume it. What do we suggest? That's where it's hard. Mm-hmm. Of that 10%, 85% is sleep.
Yeah.
So if I've got somebody for 45 minutes 3 times a month, and they ask me these questions, should I go to recovery technique X? You sure can. You're a consumer. If it makes sense to you, if it feels good, absolutely. Unless I think it's contraindicated. Yeah. But how do you sleep? Mm-hmm. Are you sleeping? If there's something to focus on, make sure you're getting the sleep you need to allow for everything we're doing to work. Yeah. I think that's the most simplistic space.
Don't step over a dollar to pick up a penny.
But in Austin, we have people that they need that penny.
Yeah.
And so they will look, and we rely on them. The people you meet, the people I'm fortunate to meet, they'll tell us, you need to look at this one. And I think that's what we'll do, and we'll always do. Yeah. Because there's so much out there that we don't know. We just need to know.
Yeah. And so the recovery piece is good. Just before that, you mentioned the sports science. So I've been over there and seen it, and it's cool. But to talk to us a little bit about, just behind the scenes, what does the sports science lab at UT look like? The force plates, the vol, all that stuff.
Sure, and it's just a whole dedicated department.
Yeah.
Dedicated department to having objective measures, and it can be. We still aren't there with can we prevent injuries? We'd love to. That's the other holy grail. When it's figured out, I'll be ready to give it to everybody. We just can't. It's still athletics. It still happens. But we can be intelligent in load monitoring. And the longer you do it, the more buy-in, the bigger the sample size. So now our scientists at the university level have 5-10 years of volume on a soccer team. And they know in a normal soccer season, what did that individual player's load consumption be? What should it be? Is it looking like it's too much and they've got a caution flag? Or is it not enough and they need to be pushed more in practice? It's fascinating.
Yeah.
and really helping the athletes.
And just to drill down a little deeper, I think on one level, of course, you're right. We haven't gotten to that holy grail of being able to predict injury, but based on our conversations and what you and I both study and hear about in the field, it seems like there is certainly progress in terms of being able to stratify risk and have more than just a flip of a coin prediction for
Yes.
whether athlete A or B or C is more likely to get injured, right? So there is some more statistical rigor and more predictive power.
Well, and especially talking to return to play. Mm-hmm. The healthy, perfect athlete, the challenge of working in pro sports, I feel like if I sprint, I might hurt my hamstring. That's a challenge. Mm-hmm. That's something that we work on with. Okay, well, let's scan your body with the NeuFit. Let's put on the machine. What feels like it might strain? Well, let's loosen it up. So we have that. On a return to play situation, much different. And that's where we can come in and pull science back. We know you were able to pull this much force pre-injury when you were a sophomore. You hurt your knee. Now you're a senior. Your left leg is 20% of where it was on that high note you had in your sophomore year. Mm-hmm. We've got some work to do.
Yeah.
Or you super compensated. You're stronger than you've ever been and your limbs symmetrical. Go play. Mm-hmm. If you get hurt, it's because athletics happened. It's not because you weren't ready. And then psychologically, that gives them the readiness to know not only did they work hard, not only did the doctor tell them they were ready, but the paper told them they're ready. They're ready. The pie graph looks like they're ready. Let's go. Yeah. So it's very helpful.
I love that objective data. I mean, for people who have been through our level 1 NeuFit certification, either in person or on videos, you'll see that I'm using the handheld dynamometer just to get some of those quick objective measurements to show changes. Because when an athlete sees that, when a patient, when anybody sees that, I think it gets a lot of buy-in, motivates them to want to continue. And one interesting thing about it that's so fascinating that I've experienced personally when people are treating me, that I've experienced working with patients, clients. Sometimes the sensory feedback can be confusing. One of my mentors had a great saying that says strain. Wait a second. Let me get this right here. Here we go. Strain is when I feel my effort. Strength is when my opponent feels it. So in other words, when I'm actually stronger and moving efficiently, I don't feel that sense of effort. It feels effortless. It feels easy. And so sometimes people can be weak, but feel like they're working really hard. So they think they must be putting out more force. And then as they get better, they actually don't feel themselves working as hard, and yet they can be putting out far more force. So the sensory feedback can be really confusing, and the objective measures there can be so eye-opening and inspiring, motivating, exciting for people to see that too. So I think there's a ton of value there. Of course, we also like it because it virtually always shows that using the Neubie creates these objective, within the session functional improvements. So I love that validation, of course, but yeah, just to underscore and highlight what you're talking about, I love that too.
And if we think quad, it's the easiest thing to talk about is post-operative knee. Mm-hmm. We know the quad is inhibited. One thing I've done with the Neubie is let's place the pads on your right quad. It's a right quad post-op. Let's get to your level of perceived uncomfortability, productively uncomfortable, 6, 7 on a 10 scale. Now on a separate channel, let's put it on your left leg. How much of this objective stimulus does it require? And I don't tell them, and I don't necessarily need them to know what we're doing. And then I'll take a look. And if it takes 48 intensity on the right side, and they get to that same level with 24 intensity on the left side, I'm not a mathematician, but that's about double. And I know there's a difference. And I don't tell them now live in fear because your right quad is doomed. If they inquire, I'd say what I'd love to see is it takes about the same amount. Let's get you within 1 or 2 on the intensity. That tells me, okay, you're back to your baseline. Mm-hmm. Your muscle is reacting the way it should when it was completely down and you were straining. You were straining as hard as you could, but your quad was not working. So it wasn't the effort. It was that neurologically, neuromuscularly, it wasn't there. And that's what we deal with day to day in an outpatient setting. So having a differentiator to help her educate is fantastic. So that's really one of the cooler things that I'll do oftentimes on those hard to wake up quads, and we're happy to see them now.
And that's a great point. I'm glad you brought that up, because that speaks to, in a loose definition of the term, there's some diagnostic value to using the Neubie, and there is legitimate value in seeing how high someone can get on one leg versus the other, if they can get higher in subsequent sessions. We talk about also diagnostic value in terms of, in one session, if someone makes a lot of improvement, we think that their issue is likely more functional, perhaps less structural. Whereas if they don't make as much improvement with a functional intervention like the Neubie, perhaps more of a structural component. So they're one of these themes that I'll just touch on briefly as we're passing by onto the next topic. But,
sure.
Just touch on briefly is that sort of, diagnostic value, loosely speaking.
Yeah, we say poor man's MRI. Look,
Yeah.
If 1 to 4 visits, you're not markedly improved.
Yeah.
As a clinician, we need to be thinking. We put our hats back on. Hey, I know they want to keep coming and they like the way the clinic feels and they like the front desk, but are we doing right by this patient?
Mm-hmm.
And using that team that we have, why would we not use those resources? Hey, can we make sure it's okay? Can you rule out things with hard data, with an x-ray, with something peer reviewed, and then come back and we'll keep going.
Yeah.
And it makes everybody feel better.
Yeah, for sure. So you mentioned a couple times now, post-op quad and, different post-op scenarios. So one of the things that I've learned about you in the years of our friendship, and then more recently officially working together, is this amazing national network that you have of surgeons. The James Andrews, the Dr. Elatroshes of the world, the people that when they have athletes in Austin are referring to you. So can you speak to how you've built some of those relationships to where people are feeling confident referring to you? And part of the, my thinking behind asking that question is for the sports medicine clinicians listening here, how they're trying to think how they can build their relationships with local surgeons to start getting more referrals for their practice and things like that. What you've been able to do on a national scale, they can do at least locally, if not also nationally, for when pro athletes are in their communities and stuff like that. But can you just speak to your experience there for a little bit?
Sure, and a lot of it has been my good fortune in having come through the sports realm. So coming from Colorado to Texas, you do meet people. We usually have team physicians. Those team physicians are usually phenomenal. They know other team physicians, and we have athletes from all over the world. And so it started there for me. That's not the only way to get there, to be somebody that others trust. I think back to the relationships. If you treat a son and the mom feels comfortable being there, that mom's more likely to grab the arm of her friend at the football game when her son tore the knee to bits. And they'll almost order them to come to see you, at least enlist you for help. And it might be, you don't need me, you need that surgeon. So it's very much relationship driven. And that being said, it is nice to have the opportunity to see those surgeries from all over the nation. And first and foremost, the consumer, the patient, and the physician need to be comfortable, because when they perform a surgery at HSS in New York and the patient's from Austin, they're coming home, their job is done, but the work has just begun. So if the next time they see them 6 weeks later, they don't have full extension and their quad looks terrible, not only am I not going to get that referral again, but the patient's in trouble. So having that peace of mind for the physician, having that communication back and forth, they know if I see a problem, I'm on the phone with not necessarily them, but their front office and their team to say, this one isn't going the way we want it to. Want to put it on your radar. Having those open chains. And that's the athletics model, where it's an availability. So part of it is being reachable. But Dr. Andrews, no one argues his impact on everything. I've never seen a more reachable physician. I don't know how he's able to do it, where he'll answer a phone call from someone that's never met him to talk about an athlete that had surgery 3 weeks ago, and he'll spend 5 minutes on the phone. Who knows what he's in the middle of? It's just incredible. That's hard to do.
Yeah.
And I don't think I'm to that level yet, but the ability to bring those folks in is a lot to do with who's helped me along the way and who's known me along the way, and then just trying to treat each one right. And if more of those happen, then it's easier to go. So on a local effort, if I had to move to a different country, I would start somewhere. I'd start with the patient. And if that patient got better, I'd thank them. And there's multiple ways to market. And then I've learned some of those techniques, and there's a lot of different ways to go. But if that person would refer a family member, I think that's the easiest grassroots effort. Because if they'll refer a family member, they may have a doctor in the family. They may have another family member that needs you as a friend. And that's really the best way to build that network, is just treat every patient like they're a pro athlete, because that's what you'd want if you're a consumer. And that's what we're trying to do, is give them what they'd get if they saw me on campus, if they saw me at the pro facility. That's what we're trying to give them for that bit of time.
That's awesome. One point that you made there that I just want to touch on, because that is so true with my observations. You talk about, you can call James Andrews and he'll talk to you for a few minutes about an athlete, even if you haven't met him before or anything like that. So many times I've seen the people who are the top, most respected, the best, the leaders in their field and stuff like that, are the ones who are willing to, pick up the phone, answer a call, answer questions, talk to people, mentor others. Just a little point on that it's really amazing. I mean, sure, there are people who get there maybe by brute force or authoritarianism, so it's maybe not across the board, but I think a majority of people that I've, who are, far along in business and are really leaders like that, are that type of person. So I think there's just a lot of value in being that type of person. Just want to kind of riff on what you said there for a moment.
Brian Gallagher says, share in abundance. I like that's one of his statements. Share in abundance, and good things will happen.
Yeah.
And I've been very fortunate of a lot of people sharing in abundance in athletics. A lot of people in this town, we have those CEOs, those executives that are amazing, that have done things I can't imagine, and they root for us. Mm-hmm. They want you to do better. They're happy when they see you doing well, and it helps you expect to try to do well. It's a lot to look up to.
That's true. That's a good point on that kind of abundance versus scarcity mindset. If you know there's enough of, whether it be respect or money or whatever to go around, patience to go around, you can cheer on other people. Whereas if you feel like, oh my gosh, if I don't get that patient, but that person does, they're going to beat me, or I'm going to run, then you have that. Yeah, that's a good aside there. Let's transition back as promised. Finally, coming back to, so we talked about the clinical side and some of the technology and things like that of offering this high level of sports medicine care in the community. Can you talk a little bit about your perspective on the business model for how to make that work? And so there's a few points that I want to touch on. This probably have to be our last topic, at least for part one here. We can always do a part two, but can you talk to us a little bit about your perspective? And this is on, the hybrid model, on payers, on, the guru model versus, being able to build a team and have other therapists versus being the guy or the girl yourself. So there's different elements of how to set up a clinic to do this in a way that, at the end of the day, of course, it has to be profitable as well if you're going to be able to do it and sustain it for years and years and years, so you can build that reputation and actually make an impact and help enough people along the way. So can you talk to us about your perspective on how to do that, not from the clinical side, but from the business side?
Sure. And I can speak from the lens of, don't do it how I did it. Do what makes sense to you. Did I do it perfectly? Absolutely not. Am I still figuring out? Yes. Stand on the shoulders of others. Look what they've done. Your entrepreneurial journey started much before mine. I was still engaged in team sports and schooling when you started. So you learned how to penetrate a market and give good care and provide great service. So our Venn diagrams were, well, I've tried everything. So people told me to go to NeuFit or come to see you. Have you heard about NeuFit? Sure, I've heard about NeuFit. I've known Garrett for years. So there's a lot of that. I think it's very dependent on where you are and the resources you have. And hybrid, essentially, for those of you know, what we're doing here in Austin is we try to take as much burden off the patient as possible. If we can use their insurance, we will. If it's not a good business decision for us to be in network with their provider, we're out. Some people are completely out, and that works wonderfully for them. Some people are in with everyone. And if you're in a town where the two biggest employers are a certain insurance contract, you might need to consider looking into them. We're so diverse here with multiple companies and large corporations that are either headquartered or have hubs here. we get insurances from all over the place, and we are able to stay at this hybrid level on those payers that aren't as favorable. And having to have that conversation with people, I think, is the biggest challenge for us. Some people don't know what they have as far as an insurance consumer. They don't know what in-network, out-of-network means. And we have to show them that value if they're going to have to stretch their dollar further than it would go if they went to an inpatient clinic. So it's very much it's a micro challenge based on your climate. And I think that's the best advice I can give is you've got to figure out what works for your niche market, whatever that is. You've got to run with it, but you still can offer differentiators. And if that differentiator is a relationship with a team or a relationship with a business owner, great. If it's a technology, then do that. And that's where I think a lot of folks in the NeuFit Nation are getting that help where they're just one person. They can be that guru, but then that means it's just them. And what happens when they have to go to lunch or pick up a kid from school? They need help. And if the Neubie can help them grow, then gosh, that's helpful. And if the Neubie can help a new practitioner gain some confidence, how useful is that? And so I think that's what they would gain regardless of in-network, out-of-network cash pay, is that they're getting another tool to help their success and make a visit outcome better. I think that's what I would look for as far as what else I'd bring into the clinic, regardless of the business model.
That's good. And you mentioned standing on the shoulders of giants and learning from people who are already figuring out a lot of these things. So one shout out for Brian Gallagher, who you mentioned and who we work with here and who was on the podcast within the last 5 or 10 episodes. It was a great one. If you haven't listened to that one yet, definitely worth a listen. Brian Gallagher of Meg Business has in that episode we talked a lot about this question of hybrid model and insurance and how the ratios will change based on where you are and all the stuff that you just said there too. But that's good. Let's see. Any other final thoughts? Things that I know we've been talking about doing this for months and months, and finally you got to sit down today.
And I think that's my final thought is we could go so many routes, and just Garrett, knowing you and what you've done, it was a shotgun approach. So I'd love to know if there's a specific problem that we could target. We could spend an hour on that someday. And I think that would be great because there are so many solutions we're looking towards and experiences we had. We certainly don't know them all. So yes. I just thank you for the time. This was cool.
Heck yeah. We'll definitely have you back on too. I'm glad to formally introduce you here to NeuFit Nation.
And Brian Gallagher helped me learn 1.5 times playback, what that meant. I just thought he was very swift with his words until I found that button. He's one of the first podcasts I really consumed in the pandemic because we were going over telehealth rules. And he had a lot at that time. And that's when he shared. He just shared. He said, let's get through this. Here's what I know. And let's get through this. And so I think the podcast world has been great for that for me when I can consume. So happy to contribute in whatever way, and feel fortunate to be on part of this podcast now.
Awesome. I'm sure we'll get some comment and feedback and questions that can lead to further episodes, and we can do a deeper dive into some different research topics and all sorts of different clinical and business topics in the years ahead. So thank you, Cullen, for joining us. Thank you, everybody, for tuning in to this episode of the Undercurrent Podcast, and we will see you next time.
Thank you.